notes that are legible, whether it's electronic medical records going on EMR where you've got protocol-based notes, or doing dictation, or just taking enough time to write it legibly. If you can't read it, it didn't happen. And if it didn't happen and you bill for it, it's fraud. Again, the October 2000 Federal Register says illegible notes, upcoding and downcoding, are fraud. Documentation is not for you. It's for the insurance company, the malpractice attorney, and the jury. You don't write those notes for you. Most of the time you know what you did with that patient the last time they were in there. This is rural medicine. I've got a client in Kansas that is a third or fourth, I think he's a fourth generation doctor in that community. And man, it's a lovely office. I mean, there's antique stuff all over the place, antique cabinets and doctors' instruments and so forth. And he's got this one wall with these small little drawers on it. And in each drawer is a bundle of 3x5 file cards, and they're bundled with twine or ribbon or string or something. And that's the medical records for 4 generations of people in that community. Back when they didn't type them, they didn't have a chart, they had a little file box, and they just pulled the file out and wrote on the card. Sore throat, told them to gargle salt water. Well, then a few years later, it was sore throat, gave them penicillin shot. I mean, you know, it's amazing to look at those because they didn't hardly say anything, just a date and a few words. That's all they needed. These people knew their doctor, and their doctor knew them. There wasn't the lawsuit or the litigation going on in society like we've got now, where you have to protect yourself coming and going by having notes. You can't do that now. Your notes have got to reflect what you did, and they've got to be legible. And it can't just be 3 or 4 words or a couple of check marks. You've got to give detail if you want it to stand up to the scrutiny of an audit. And when the audit occurs, you will have to pay back money if they don't like the notes. Okay? It's important that if you are going to bill for the interpretation of an EKG or X-ray done in your clinic, that you also put that in the chart notes. Simply circling the EKG strip or marking some squiggles on there, no, that's not enough. Well, but wait a minute, Jim, our EKG machine prints out an interpretation. Well, that's fine, but you've got to say it in your notes. You can't just attach that into the chart. It's got to be in the SOAP notes for that date of service. You must, if you're going to bill for the professional component, and you should, you've got to say it in the notes. It's important for you to code correctly. Sometimes your billing staff's going to come to you and say, Doctor, I need to know how long was that cut, how deep was that cut, was that the result of an airplane accident, did they fall off a train or off a bicycle? And you're going to go, why do you need to know that? You do your job, I'll do mine. Well, they're trying to do their job. Because you see ICD-9 coding, it makes a difference if it's accident related or not. It makes a difference on how deep it was, how long it was, how many stitches you had to take. And if they don't code it right, you won't get paid right, especially in insurance claims. It's not quite as important in Medicare and Medicaid claims on the ICD-9 diagnosis code, but it is still important. So you need to understand that. CPT coding essentials for the provider. Evaluation and management codes that are used for the office visit are the basis for reimbursement from all your sources. While coding will not affect the Medicare reimbursement in the rural health clinic, it does affect the copay or co-insurance that's paid by the patient, their supplemental insurance, Medicaid, or on the cost report. You see, this copay and deductible will be paid to the rural health clinic by somebody, guaranteed. Kind of like that Cajun cook, I guarantee you're going to get that 20%. If the patient or their insurance does not pay all the copay amount, then it's written off to Medicare bad debt, and the rural health clinic receives that money in the cost report settlement. It's hard cash dollars. It's added into your settlement. It's not just in the cost, it's money that you get. Freestanding clinics get 100% of it currently. Hospital-based clinics receive 70% of the Medicare bad debt amount.